are in listen-only mode.
Hello, welcome to the online ISP forum for May 23rd, 2013. My name is Dan McCloy, and I'm part of the team that provides support throughout Oregon on person-centered practices in the 24-hour comprehensive ISP planning process. We're glad you're able to join us today. This webinar is being brought to you by the Oregon Technical Assistance Corporation. OTAC has been providing training and technical assistance to professionals and citizens concerned about intellectual and developmental disabilities since 1984. OTAC is available to answer 24-hour ISP process questions. If you have any questions or comments after today's forum, you can reach us at www.otac.org/ISP/support or at 503-428-5435. Participants in today's forum can submit questions through the chat box on the webinar console anytime during the presentation. We'll have time for a short question and answer section at the end of the presentation. The webinar is being recorded to share with others who weren't able to attend live today. Your telephones and microphones have been muted for this call. The recording of today's forum will be posted later today on the OTAC website. With us today is Alan Lytle from the Individual Support Planning Team here at OTAC and Teresa Rittner, RN. Terry has been a registered nurse since 1976. She has worked with seniors and people with disabilities for 18 years with the Office of Licensing since 1999. She is the lead licensing specialist and the only nurse on the team. Today, Terry and Alan will talk about documentation issues, issues of risk, and the importance of support documents. We hope to have plenty of time today to answer your questions. So thank you for being with us, and I'll turn it over to Alan and Terry.
Well, good morning, everybody. Good morning, Terry.
Thank you, Alan. Good morning, people.
Glad you're all here with us. And this a day that Terry Rittner is here for an online ISP forum is always an exciting day to me. And I'll tell you what, I think it's not just an exciting day for me, but it's an exciting day for a number of you guys because I've said it before when Terry's here. This is always one of our highest turnout for an event, and sure enough, we have over 100 people pre-registered for this event, and that's just specific locations where people are connecting. And I know I've heard from several sites where they're getting together, and several people are sitting together to watch the webinar today. So hello, groups of you sitting together and watching and listening.
And I want to thank everybody for coming. It's really, I know it's difficult to take time out of your day and your busy schedule, but it's really appreciated by myself. I want to give knowledge to people so that you have an understanding of the issues we're going to talk about today, and hopefully when you see me you won't be as confused or nervous about me. So again, welcome, and let's get rolling.
Yes. So as far as outcomes of the conversation, some of you may have attended our webinar last year in June. Terry and I had a similar conversation. So we're going to continue that conversation today. We are going to cover some of the material that we covered last June and hopefully share the learning that we've both had since last June. So so we're going to just continue this conversation today. So you can expect today a better understanding of when written supports are required, what written supports include. By written supports, we're talking about support documents or instructions for staff. We're going to talk about balancing things that are important to the person with supports that are important for the person. And we're going to have some conversation about when the team decides something is a risk. What do we do? When the team believes something is no longer a risk, what do we do? How about when the individual decides not to follow a doctor's lifestyle change recommendations?
Or when somebody on the team disagrees with a physician's order for medication, treatment, or therapy.
Yes. And we just got some feedback that Terry is hard to hear. So I'm just going to slide this microphone over a little closer to Terry, and so we make sure we get volume up there. Thanks for that feedback.
Yeah, hopefully you can hear me better now.
So we thought we would start with some conversation about just some basics of documentation. And so, yeah, let's talk about documentation.
Yeah. Well, the reason, as you see, the reason for the ink color is that your documentation is a legal document. So you need to be able to make sure that if it's needed to be called into litigation, they're going to make copies. And so it needs to be printable. A lot of colors don't show up very well. It becomes an issue. The timelines of complete documentation is the time of the event. And I know in staff schedules sometimes it needs to be just a little bit after, but they need to note the time of the event. So being really careful to get that event documented down. Then the staff, besides the individual's name on their record, you need to make sure that whoever enters some information, they have their name, and that is completely dated, as I said before, including the year. It's very important. If things get mixed up, and especially for paper, if it gets dropped, it's not clear what the year of the information, or even if it's in the record, was it put in on what date it was put in. Being respectful of confidentiality of other people supported. We've said initials or first names or something that doesn't identify the person completely, because that information that's being entered is confidential about them potentially. And so if that record is utilized, you don't want to have them more discovery about information that's not pertinent to the person.
Yeah, so if I'm writing in John's chart notes about something that happened with his roommate, Mike, I'm going to be pretty careful about what I write about Mike in John's chart notes.
Right. And then be sure your information is clear, specific, and objective. Be really careful with objective. Don't put in feelings, thoughts, make evaluations, or identify, make a decision about a medical diagnosis that you aren't qualified to make. And really specific about what goes on. Information, if you can make it really clear and specific and make it real objective, a lot of times it can be pretty succinctly put, but if it needs more information, be sure to put it in so it's really clear what you're documenting about. As I've said before, your documentation is a legal document. So it is a part of the record, it's part of the legal record, it's part of the information that's kept for the person. For our purposes, we're only looking at 3 years or 5 years, but the legal system, you need to be really clear on how long you have to keep that documentation. It's just like any other legal document, especially if it's on care. That's really can be called into question later on. Acknowledge late documentation. Life happens. Things happen and you forget to put something down and you realize that. Acknowledge it, just set the date and that it's late documentation, and then put in the information. So it's a late documentation date 4, so that you know that it has been entered later. If it's not in sequential order, it looks like you've falsified the record, or if you try to squeeze it in, again, it looks like you've falsified the record, and you don't want to do that. Remember, it's a legal document. So other considerations, your agency or your organization has policy and procedures. It's a requirement for 24-hour, for supported living, for employment, and for some children with Proctor Foster. The agency is required to have policies and procedures regarding documentation. So you need to look at that and make sure you're following that, because not only do we have expectations, but your organization does. So you need to be really clear on that. And then really get, when you're trying to document, really, these are the questions you need to be asking. Who is it? What's it about? When did it happen? Where did it happen? Why did it happen? And how did it happen? Because you want to know, especially, say you're looking at incident reports, the why is very important, or somebody comes along to review it. Why did it happen? There's all that information that may give you the information you need to change things. So if you don't know why it happened, you say you don't know why. But if you do, it needs to be clearly documented because things could be changed, and it should be if it's a problem for the person.
Answering that question of why is sometimes a tricky one, because what we also want to keep in mind is that that point from above that says making sure the information is also objective. So as you're answering that why, you do want to avoid jumping to conclusions or making assumptions, but figuring out what you know about the why based on the facts that you observed.
Because it can be really, the facts would be what was happening at the time, whatever you're documenting is about. Because that's the clear why. It gives you more information about what's going on with that individual that may need to be considered and thought about later.
Right. So let's talk about support documents. What are support documents?
Support documents are written instructions that tell the direct support staff what to do to keep the person safe around an identified issue. So you have the Fatal 4. Here's the protocol for
the general protocol.
Yeah, it's just a general. It just has the components with your ISP manual. It gives you directions. But the critical points are what is the risk and how do you know it's a risk? And that would be off your risk tracking. The preventions. We require you to have prevention. So if you don't have it, you need to make sure that there is something identified in there because that's the whole intent, is to prevent it. The signs and symptoms, so direct support staff can identify when there's a problem or a potential, and then what to do if the signs and symptoms are observed, and then of course at the end, when do you know it's a critical or think it's a critical, and calling 911, especially for the Fatal 4. Remember, you do not have to ask your supervisor for calling 911. You all should have had training about that. You need to err on the side of caution. If you're really concerned about a person, then you should take action. Okay, when a support document is needed, it's when a risk has been identified. So you go back to that risk tracking record, and I see here that for question 52, the person engages in physical aggression. So it tells you right there what you need to add on to the risk page of the ISP. And then it says, according to the manual, is that you need to develop a support document. So remember, we talked about the support document. It needs to say, how are you going to try to prevent it? What are you going to do about when it happens? And to the point that further actions are needed. The proper problems we see a lot of times are, yeah, that the risk has been identified and very clear, but the instructions on what to do to prevent it is not as clear, or when is it a significant risk that maybe further action needs to be taken. So those are things you really need to pay attention to when you're doing a support document.
You know, it might be valuable to have a quick conversation about just the terminology of support document. I was even in a meeting yesterday where there was just some question that people had between, you know, is a protocol a support document? What's a support document? You know, you can ask 6 people that and probably get 6 different answers. Just so you know, the language that Terry and I use during our conversation here and what you're seeing in print here and throughout the conversations about the COMP ISP, the comprehensive ISP, we refer to support documents as all documents that are in place to support any identified serious and significant risk. So the way we talk about support documents include protocols that are in place to address those serious and significant risks, things such as safety plans, financial plan, behavior support plan. All of those are included in the conversation of support documents.
Correct.
Oh, and a little reminder here that the risk tracking record, you can see an example page here. That RTR is the tool that is intended to help ISP teams identify all of the serious and significant risks present in the person's life. So once we've identified one of those risks through the RTR, it moves on to the ISP, and then the team decides how to what documents will be in place at each location, home and work.
Right, but you need to make sure if there's a risk identified, you need to put the support in right away.
Yes.
And keeping it current. So this is a risk tracking record. If things change and something is a new risk, you need to update it and put the support document in place right away. So just keeping that in mind, it's, the support document should be current at any time. If things change for the person, their situation changes, gee, they're like me, they're getting older and things that were happening when I was younger don't happen again, anymore, then you need to be looking at that and really taking that into consideration if it's a current risk, which I think we're going to talk about a little later.
Yes. And here's that point that you were just tucking in. If you identify some new serious or significant risk, be sure to put supports in place immediately. I know I said the team decide what support document. Ultimately, the team will review and approve support documents. But as a provider organization, it is your responsibility to implement supports immediately to address that serious risk, even if it will take longer to build something more thorough. You may know a full behavior support plan is going to be needed, and it will take time to develop a functional assessment, but you need to have something in place right away.
Right, and being looking at your ISP as to how changes are communicated, because it may be that you just notify them, and then that will go on later to give them the actual support document to look at.
And in the ISP manual, these are referred to as interim supports. And page 66 of the ISP manual explains some things to think about with interim supports.
What does a support document include? There's the Fatal 4, and those are required documents. Use that form, and I know some people have issues with it. Use it the best you can. Remember, when there's things on there that you know happen that are not on the form, use the other section. The other one that's required is the financial plan. So we really, you know, just from a licensing standpoint, we really look at those because you're telling the direct support staff how to support that person and what things should be in place. Then if there are other supports, like Alan said, there's behavior support plans, there might be other things that need to be put in place.
Safety plans.
Safety plans. Those are all designed by your organization. You may have a format that you utilize. We just look at to see that all the components that are identified are addressed. So if there is a risk, there's how do you prevent it? How do you address it if it's seen? And when is it critical and immediate action needs to happen? Remember, support documents always include specific instructions for the location where they're used. The problem I see frequently is that a support document has been written for home and just kind of made a few changes for work. And then when you ask, are these the things the support staff are supposed to do, it's no. So remember, write it for the staff. That's what support documents are intended for the direct support staff to understand what's required of them when the issue happens and how to prevent it so you don't get to the point of needing an intervention of any sort. So remember, always write it to the specific location of use.
So here we have that basic outline of a support document. Terry just had started to outline what a support document includes, that description of the problem or the issue, what steps you're going to take to prevent it, signs and symptoms that the issue is happening, what steps should staff take when they observe that problem happening, And if necessary, especially around health or medical issues, circumstances when 911 needs to be called, you may also be considering circumstances when they need to notify their supervisor or take some other action to notify somebody else about an issue.
Right, and it's really important to have all those components in it so you really have it spelled out for the direct care staff. And then the author and the date. You want to make sure that the date that's on the document matches the date that's referenced on the risk tracking or on the risk page of the ISP.
And that's the most current
And
version
that's
of
the most
document.
current, because when you change things, the ISP is supposed to be a living document, and it's really supposed to be reflective of the supports that you're providing. So if you're changing them and not updating that, it needs to be clear to the staff too which one works, because I know I see sometimes 2 and 3 different documents for the same issue. So you want to make sure you have the most current, so the author and dates on it, and that it is kept where you say you're going to keep it on the risk page of the ISP. And if that changes, then just get it updated so it's really clear and it follows really what you're doing. So there's no question of where you're going to have that information and what information are you following.
Anytime we have a conversation about support documents, we have to talk about balance. And we're always thinking about how do people have choice and control in their lives without serious risk to themselves or others, or how do we balance the risk that's inherent in any choice that we might make in life, and being able to choose things that are important to me. So we struggle with that, and our job as team members is to understand what is needed for the person to be happy, healthy, and a valued member of his or her community. Did you have a comment on that?
No, I just wanted to, it's a real, you may not have, I always see it, and they're having discussions, and we haven't come to an agreement, but the issue is you're having discussions. Don't just say, well, we can't agree, and we're just doing this. You have to have ongoing, and especially for people, because people change. Mm-hmm. And it's critical to get them the information in a way they understand the actual, what you're talking about. So if you're not presenting it in a way that the person understands, then there's no way you're going to have any balance. So it's really working hard to make sure that the person's happy, but you're going to be struggling to be healthy or safe. So you're looking at that interaction, and looking at the situation of how have you presented it, because that's what I've seen. And it's hard not to take our own values and our own judgment and put it in there, but we are going to look to see that you are trying to keep the person healthy and safe, and yet focus on what makes them happy and what their desires are. So there's no simple solution or formula. Be sure to not forget that you look at the things that are important to the person when you're providing support around complicated issues. That's so often I see that it's just going to be provided, and there's no discussion about what other options, what part of it can you honor and that the person wants, what part of it is non-negotiable, and you need to maybe include some teaching for the person. So you really got to look at that really hard.
Yes.
So we've talked about the striving for balance and looking for issues within the support documents that conflict with what's important to the person. So when you're going back and identifying what's important to the person, you should be looking at those support documents, which would include the nursing care plan if there's a nurse involved, to see if there is conflict in what's important to the person, because then the team needs to be discussing it and figuring out, like I said, how do you honor the person's wishes without putting it in harm's way as much as possible. So, and you know, that we look at, and we really look at those support documents and what's important to the person that you guys have identified, because we don't know the person. So it's really important to make it really clear what's important to them, and making sure that those support documents look at that issue too.
And folks, these are challenging conversations. We know it. It's challenging when you are wrestling with knowing clearly what the person wants in their life, and also having some list of things that seem pretty black and white about what has to be put in place to keep the person safe. We've got another, as we reach the end of this presentation, we've got a link that we'll provide to show you, and that you can look at on your own, an article on risk and a person-centered approach to risk. Just one other article that's available that can help you think through some of these issues of recognizing that there's risk inherent in all of our lives, and it's not easy, but we wrestle through it as a team.
And that there's real good conversation, and you document the conversation. Remember, we're talking about documentation, so you want to be clear on the documentation of what you've considered, what has been discussed, and what has been decided. So again, if a conflict has been identified and not resolved, there needs to be an ISP team discussion record to reflect all that, and what you're going to do about it, because you can't just say, well, we can't decide. You need to discuss it. You need to think about when are you going to revisit the issue, because again, it may be a limited issue, it may be an ongoing life issue. How are you going to continue to think about it, even though you can't resolve it at the time of the ISP? The discussion record should show the person's perspective and the ISP team's perspective about the issue. So that needs to be really clear, because you want to know what the issue is and what can't be resolved, and like I said, what has been discussed and what has been considered. That's okay. We're striving for balance, and the nurses, you know, I'm a nurse, and my whole being a nurse has been, I want to take care of people, but I know best. So, you know, that's really hard for a nurse to step out of that comfort zone. But when you see something that is in the nursing care plan, and it may be it's against what's important to the person, or you're looking at it not quite clear and you're a little confused, discuss it with the nurse. Only the nurse can make the changes to the nursing care plan, but you need to have a discussion so that you may not understand the point and the view that the nurse is coming from, and they may be able to explain it and maybe need to put it in more in different terms so everybody understands it and agrees to it. If it can't be agreed upon, then the ISP team needs to have a discussion and weigh in with the nurse. But don't go in changing the nursing care plan. You really don't have the authority to do that. Look for opportunities to compromise or adjust the supports to move toward what's important to the individual. I talked about that really, you know. We've talked in the past about diabetics. Can you move toward, you know, looking for options that will get them there? You know, just because they're a diabetic doesn't mean that they have to be regimented. So you look for that and look for teaching. What are those teaching moments? What can that person be involved in to help them? Can they be involved in their menu planning, their food choices, their shopping? You know, do they understand the exchanges? Does a person really want, you know, overweight, so their doctor orders a diet, but they don't want to follow the diet, but they don't understand the ramifications, the complications, so it's teaching. and looking at how you can work with them to maybe work them towards something that's a more healthy lifestyle change. There are some things that you see and it continues. The issue is continue to work with the person. Don't give up. We all change, we all grow, and we all change our minds.
Nicely said, Terry. I love this quote. This comes from Michael Snow. Happy and dead are incompatible. So simply saying, well, he chose to do it because that's what he wants to do. Well, happy and dead are incompatible. But the flip side of that is alive and miserable is unacceptable also. So this to me just captures the struggle that we have as team members, and we're trying to work toward providing that balance of how close can we get to what the person wants while still maintaining a reasonable level of.
Right, and we're all people, and we all struggle with choices in our life and situations. So everybody's going to go through that. So you're going to have to be real creative. You're going to have to continue to look at it. I don't know about you, but I still look at everything in my life that's a struggle for me. I'm looking at how can I change my way? Will I be effective on it? Gee, I slipped and went back. It's always an ongoing process. So you can't say, we're going to do this and it's going to solve it.
So now we've got a sequence here in our presentation of what to do when. And the first what to do when is what to do when the team decides something else is a risk. And sometimes this happens even before there's a whole team discussion. Sometimes just the provider organization, I would say more often than not, the provider recognizes that something is changing in this person's life. There's a new risk going on. So what do we do?
So risks are added to the ISP if they've been identified on the RTR. If the ISP team identifies an issue that wasn't covered in the RTR, remember you have that other sections, like I said, in not only in the fatal fluke protocols, but also in the risk tracking record. So it gives you options to add things that are not part of the questions that were in the risk tracking record. Use those, list things. I see a lot of people are utilizing them, and that's great because it really is getting to the issue of what the risk is for the person. And really remember, list the risk. Sometimes I see an identification, but how is that a risk? So the risk is really what's, to the person, not the diagnosis or, et cetera.
Yes. So how about that situation when the ISP team decides something is no longer a risk?
So you're going to have to go back to that RTR, and you're going to have to say you change the yes to a no or a history if it's possible. And then you're going to remove the risk in the support document from the risk page. So remember, in your ISP, you will have the identification of how changes can be made. So you want to really do that, and that, and it may be, doing this, and then just sending out that change form that you verbally get team approval and send it to the CDDP or the services coordinator. So really, how simple can it be? I know that a lot of, we're getting more agencies and providers not documenting on that, there's a change form and then attaching a signature page. So really look at your ISP, and that's why you give yourselves options to make it simple, to make the changes, to keep it a living document that's really supporting the person.
Other considerations when the team decides that something is no longer a risk. If it's a behavior or a mental health issue, there can be a lot of complex issues behind discontinuing a risk. We want to think about, are you not seeing the issue anymore because of the supports that have been in place? So you want to make sure to complete a discussion record. Add that to the ISP to document the team's discussion and decision about your choice to discontinue this risk. And the ISP manual goes into this on page 63.
But like Alan said, it really needs to be because it's no longer a risk, not because the support document you have in place is working.
Exactly. So that it may be that what the team tries is, if you think that it really is gone and the support document isn't actually needed anymore, maybe part of your discussion is we're going to try phasing out some of these supports to see if that issue comes back before, you know, that's all going to be part of the team conversation and the team's decision about how to proceed with that issue.
Right, but there's some things to consider. You can consider as the health needs or issues for the individual changed. Has their mental status changed?
Sorry.
Has their, they've aged. We all age. And the physical abilities, maybe a decline. So you really look at those, you know, those factors and look into that and say, is this kind of the reason why you're thinking it's no longer a risk?
So
So that's, you know, with the reasons risk has.
this is making that point.
Yeah.
Is it because the support that's in place is working, or is it because the behavior is not being displayed and would continue to not be displayed if the support was removed?
Right.
That's what where you want to be.
Right.
In this conversation.
And that's, you know, that's a great. Gee, if the support's so successful, it's a great support because it's preventing the risk. But if you take away all that great support and the person all of a sudden that risk puts them in jeopardy, then you've really not thought it out. So that's the challenge that's put to you when you're looking at taking away a support.
So let's talk about that history designation on the RTR for a moment.
So there's, this is changing things that, like I said, maybe the person's medical history has changed. They're no longer physically aggressive, their physical abilities and they just don't pay that attention, whatever. It now becomes history, and you go back and you look at the ISP manual about when you turn it to history, and then you can make it a history, because then it's acknowledging that it happened in the past and that you don't have a support document in place, but it's to be aware of in case it reoccurs. But it's really, like for seizures, I know that the history piece, you need to make sure that all the components are there, because even if it hasn't seen a seizure, the person's taking medication, that's probably controlling the seizure. So you really need to read those questions carefully and read the ISP manual on the instructions on how to make that change.
My family just wrestled with an issue just that directly relates here around physical aggression. And Grandma had a surgery and was in the hospital. And after the surgery, she was on morphine and various things to control the pain. And part of her experience was sheer terror of what was going on around her.
Sure.
And she physically grabbed at the physicians and nurses to the point where they had to decide as a team that she needs to be tied down in her bed. And there was that very physical, mechanical restraints that were in place for a period of time in her life. It was about a week where there were some really challenging situations going on for her. If there was a risk tracking record in place for her, we would be saying yes, that physical aggression is present in her life. Fortunately, for Grandma and for our family, her medical situation turned around, and she's on a great recovery at this point, and she's moved completely past that point. So if we were filling out an RTR for her, we would move that yes to history now, because it's a past problem, but we don't need any supports in place at this point.
Yeah, because you really need to consider when you're considering the history, why did it occur? You know, there's, you know, you look at the living situation people come from.
Yep.
You've got all the changing staff in there, their life that don't know them and don't understand them. And so it may be a communication issue, a power struggle. So you really need to look at that as part of, you've identified it. But if that person all of a sudden is in a situation that they're very happy, they like where they are, they like the people they're with, you know, that aggression may not be an issue for them because it was a response to a situation and the environment. So you really have to, you know, start talking about weighing it.
Mm-hmm. So history comes in handy because it helps us remember if, you know, in our case, because, you know, we're family and we're going to keep in mind if grandma ends up back in the hospital again, if she has surgery again, if she has morphine again, we're going to have this conversation in advance. We're going to talk with her support team about what supports might be needed to help keep her and everybody else safe. And that history can provide that benefit in this situation as well. While you're not going to have current support documents, you're going to retain that information if circumstances change again. Great. Here's another what to do when. What to do when the person or the ISP team decides not to follow a doctor's lifestyle change orders or recommendations.
Yeah, and that's, you know, the do not smoke, do not follow, you know, the diet restrictions, other lifestyle choices. They're really, you know, people have it right, just like we do. And that goes back to that education. Do they understand the consequences? Do they understand the choices? Can you help them make some baby steps? Really looking at the education of the person is one of your first things. And then reviewing with the individual, and if it's in order, keeping that prescriber informed. You know, recommendations are recommendations, and that's what you try to help the person through. When it becomes a lifestyle change order, you're just going to have to, you know, this person should not smoke. Well, you know, doctor, you don't have the right to tell a person that. You can suggest they not smoke, but you can't order them not to smoke. But you need to look at the situation very carefully. Say a person with chronic obstructive pulmonary disease is on oxygen and they're smoking. There's a danger there, and you guys need to be working with it. The person has a restricted diet because of a medical issue. How can you work with that person and make sure that in some way they're making some headway at it, or are you just saying it's the person's right to refuse? You know, it's everybody's right to refuse, but to understand the consequences and what's going to happen, because I've seen this happen in the past in a situation where the person wanted to drink, and the doctor saying no alcohol, and it wasn't because of the medications, it was because the person couldn't swallow safely. And so they really had to work it out, and it really came down to the person understanding the consequences, being told in a way that they knew what would happen and the potential outcome if they continue to take oral fluids. So it's really looking at that. Have you done everything you can? Have you really done it to the person's ability to understand it and their comprehension?
Here's another what to do when the person or the ISP team disagrees with a physician's orders for medication, treatment, or therapy.
If you're questioning an order, you need to be working with that prescribing physician. There's the need for that. The physician may have ordered it for a reason. You may have a policy and procedure in place that says that type of order can't be followed. So you need to educate. Sometimes it's just educating the prescribing physician. Sometimes it's, again, the doctor ordering something that is you can't follow because of the person's rights. Again, it's education. If you disagree with an order that the doctor has said for a medication or something, you need to be talking with that physician or prescriber to say why you think it's a concern. You know, as a nurse, I'm charged with acting on behalf and being an advocate for any person under my care. And so if I have a question about an order, it's my responsibility and my duty to question it. So sometimes it's just getting some information of why it's happening or giving the doctor some information, the prescriber some information they don't have, and why it's a concern because they don't have that information. If there's a consultant or a specialist that, say, the doctor wanted to see and then the recommendations or the orders come back and you have a question with that, you know, take it to the PCP because they ordered this specialist. And, you know, doctors don't agree and prescribers don't agree. So sometimes, again, that specialist, whatever they recommended or ordered, they don't necessarily have all the information about the person, where we hope the PCP has more and can make that judgment. Like I said, you need to make sure you're clarifying the situation with that prescriber and making sure you're documenting it, especially to tell the story of what you've taken, the measures you've taken. So, you know, it may be, gee, a family member as part of the ISP team has questioned a new order for a medication because they know in the past the person had it prescribed, it didn't work, and they're really concerned about it. Well, the prescriber may not have that information. So you really want to talk about it, why you're concerned, what are you going to do about it, document it. So if it rises again, you have a clear description of what happened. So, you know, you're doing it for the person. And so document so that anybody who comes in who looks at that can understand why the situation arose and what kind of solutions came out of it. Because it may go on for a while. It's not like it's going to be taken care of today.
Who should author a support document?
Someone who knows the person well and is familiar with the issue and can write clear instructions to their direct support staff in the setting for home, work, or other. Really, you know, if it doesn't reflect what staff are supposed to do, then it doesn't belong in that document. So if you have a document for home and all you've done is just put work on it, remember that's the instructions you want the direct support staff at work to follow, but it's not, you know, notify the nurse. You really need to look at it and read it carefully. So does it tell me what I'm supposed to do to support this person while they're here in my care?
You know, as we consider the question of who should author it, I noticed we've been reviewing the questions that have been coming in, and somebody asked a question if the author of a support document is expected to sign it. And no, the author of a support document is not expected to sign it. Only when a nurse when a nurse is following the issue that the support document is addressing, then the nurse would sign that support document.
And it's, you know, what you're doing when you identify the author is just keeping a record of when it was, you know, who was it, because that person may leave and you have somebody else come in that position, but you're maybe going to follow that for the years because it still meets the person's needs. So you just want to make sure who authored it. If it needs to be revised, then you would have, and it's a new staff or a new person is going to be directing that, then you would have them be the author.
Yeah, so the answer to this lady's question, is it okay if someone different makes changes who wasn't the original author? Absolutely. Yep. The one situation is when when it's a nurse, when a nurse is involved, then, Terry, comment.
Then the nurse has to make the changes.
That's right.
You need to be working with that nurse if there's something changing.
And if it's a new nurse who's come in, there may be a new nurse who's come in. You don't have to go back to the old nurse. If the new nurse has come in and is doing an assessment and has a plan of care in.
Right, and they can just sign off on it and then accept it as long as it does meet the person's needs. So that's the key. When there's a change in nursing, you know, the assessment has to reflect what's happening and be in agreement, and the nursing care plan needs to meet the person's needs and be reflective of what the nursing services are and what the nurse expects, and those protocols that the nurse directs need to be pertinent to the care that the person's receiving at that time.
So for many years, I took somebody to a neurologist who closely monitored her seizures, and the neurologist wrote very specific timelines for responding to seizure activity. Do you recommend that we hand the seizure protocol to the neurologist and ask him to fill it out for us?
Absolutely not. That then becomes an order, and it's like any other order, you can't change it. Only the doctor can change it. What you do is get those doctor's orders in place, you include them in the protocol, and as the doctor's orders change, you update your protocol, do your change form. So it becomes a fluid. Doctors do not want you to call them to say, I need you to change this and please sign it.
Right.
That's not a good use of resources nor the physician's time, and you don't want to alienate them.
And the doctor may just want to, write a very quick and simple note that he has explained to you in the meeting, in your appointment. He may have explained it so that I understood it, and that's exactly what he would do. I would understand that his little quick scrawl on there meant, if after 5 minutes of this particular kind of seizure that we had been talking about and I understood, 5 minutes of that we needed to call 911. Well, my job then was to take it and write it in a way that staff understood that and could follow it consistently. So to really describe that seizure activity that the doctor and I had just been talking about, and to write that in a way that the direct support staff could understand and follow.
Yeah, I remember Alan said, the people who are writing it should be people that know the person.
Yes.
So that goes back to that issue. If you know the person and you're writing it, you're giving that information to the team so that they can look at it and come to some agreement.
Should agency nurses sign off on all medical protocols?
No. The agency nurses should only sign off on the protocols that are directed in their nursing care plans. Nurses, and I'm sure agencies, don't want to pay for the nurses to be taking care of everyone, nor should they be. But it really needs to be only those individuals the nurse is providing support to, and part of that nursing care plan includes that health risk that is addressed. So the nurse should be either signing off. I mean, you can have a non-medical and the nurse working on the support document, an aspiration, or etc. The nurse is going to have to sign off on it and agree that it meets the person's needs. So
yeah, that was a good point. Someone else, such as the program manager or a non-medical person, might have written that document originally. That's also just fine. That's what we're hearing from Terry.
Right.
But the nurse would review it, if necessary, make any modifications to it, and then sign it.
That's correct.
Evaluations. The manual, the risk tracking record tells you that an evaluation is required in certain situations. There are certain situations around assessing whether someone's at risk of aspiration, whether someone's at risk of constipation in a specific situation, assessing whether someone may be at risk of a serious behavior or mental health issue. And in all of those cases, when the risk tracking record says it requires a current evaluation, we just wanted to point out that a current evaluation, an evaluation is considered current if the team knows the condition the person was in at the time the evaluation occurred, and the person's condition is not significantly changed since that time. So you're not expected to have a new evaluation done, for example, every year. It would be subject to the person's needs changing. If the person's needs changed, 6 weeks from now, we would likely need to have a new evaluation.
Right. The biggest question I get is about the oral motor evaluation. So when, after the end of the aspiration dehydration questions on the risk tracking record, it says that then the evaluation needs to be performed, and you need to document the date and where it's kept. Well, an oral motor evaluation can be explaining to the physician what you're seeing, and it's not just saying we filled out a risk tracking record and this is we're told we have to do it. You need information about what you're seeing. What maybe the person only has gastroesophageal reflux. Do you see any coughing? Do you see any problems? Describing that, taking the person, saying, here's what we're concerned about. Would there be an aspiration risk? Then it's up to the PCP to determine whether a swallowing test is necessary and who's going to do it. Don't go in and say, we've been told we have to do a swallowing test. That would infuriate a physician, and it's not accurate. So what you're asking is, does this person really have any potential for aspiration? Are they not drinking well because it hurts to swallow, or they start coughing, or they just not eating well because they don't like food? I mean, it's really looking at the situation and getting that information in place to present to that PCP.
And a tip there is look at what the question is that triggered you to have that evaluation, and make sure you're taking evidence about that issue to the physician. So if the question you answered was, does food or fluid fall out of this person's mouth when drinking, make sure you're talking about that to that specific issue to the physician. Say, hey, we've noticed that when she's drinking, a lot of fluid falls out, and not just simply walking into the physician and saying, can you tell us if she's at risk of aspiration, but presenting that information that triggered this question.
Same thing for a person who drools, there is, say, in the warmer weather, they really don't swallow well because of whatever oral motor skills, or even could be a surgery that happened that's causing them not to be able to swallow well. Does that impact on their ability to get the fluids? And so you're really looking at all that information. You're taking it and giving it to that prescriber to say, here's what we're seeing, here's what our concern is. Can you make a judgment call to say there is a risk or there isn't?
I have to say, it has happened again. Terry and I have managed to talk an entire hour here together, so we're nearing the end of our agreed-upon hour. We have a couple more slides, and so we'll go ahead and stick around for a few more minutes so we can make sure to go through this. I just wanted to give you a heads up. It looks like we'll probably have about 10 more minutes of presentation, and we hope you'll either be able to stay with us or watch a recording later if you have to leave now. One thing here, as we move forward to the next slide, we have covered now some of this stuff about nurses. In our earlier conversations here, but I just wanted to point out, if you have more questions about the nurse's role in interfacing with the individual sport planning process, take a look at the manual, page 122 through 124. It gives real clear instructions on beginning nursing services, continuing nursing services, and discontinuing nursing services. And all the things that Terry and I have talked about already today and in other sessions are written there. That's past information, so we'll move forward.
Yeah, the one thing I want to point out is if there's a nursing care plan and the risk page indicates that the nursing care plan provides the support both places, then is there agreement that the nurse is providing that support, or is there the nurse working with the staff at the employment site to make sure that there are supports put in place that are reflective of what they have identified? because I see a lot of times this nursing care plan is identified as a document of support, but the person does not have the nursing services there. So you need to really look at that and talk about it. So that's one of the conflicts you would see at during an ISP meeting that you need to discuss.
Yes. And a quick conversation about supporting challenging behaviors.
Just making sure that positive behavior support is based on people had things that are important to them. There are positive contributions by every individual that they can make. Understanding the person's strengths and skills. How can we better support them to get what's important to them in their life? And how, if we do a good planning, how do we minimize the need for any intrusive nature of any intervention so that they have a balance of health and safety. So remember, a positive behavior support plan really is going to emphasize on that. So
capitalize on people's strengths and
yep,
skills
yep,
to move them toward what's important too.
And a behavior support plan really should be, that's your prevention should be your major role of what can you do to support the person and make sure that their needs are being met before they need to get to the point to show you that they're unhappy.
Yes. Implementation is so critical, and so we have to take a minute to talk about implementing support documents or any part of the ISP.
Yeah, we've talked, the documentation, that staff are trained on the support documents. And then it's the responsibility of the provider to make sure they understand it. So remember, just having them sign off that they've read it does not necessarily mean that they comprehend it. So you need to be really aware, does the staff understand it? And then make sure that they are following in the documentation requirements of that support document. Is it being documented in a constipation protocol? Where does it say you need to have that documentation? Is it being put there? And then, is it being followed? That's the really the key to understanding is, Judy, do you understand it enough to take action when it says take action?
And then there's also some responsibility for the manager or whoever reviews the documentation of the direct support staff, who's looking after data that's being collected to see if a problem is evolving over time.
Yeah, because remember, if it's important enough to document, it's important enough for somebody to look at it.
Review it. So if you have orders that say we are supposed to take a certain action if there's been no BM in a certain amount of time, staff may be following through and documenting every BM or no BM that they observe, right. But are you catching?
Right, and being clear on, you have physician's orders that say if no BM in 3 days. What we see is on the 4th day actions taken. So you need to be really clear with that order and with that protocol to say, when do you take that action? If the doctor says 72 hours, it's 72 hours. Oh dear, it happens 2 o'clock in the morning. Do you really want to wake that person up? Look at what is really the common sense, and then being really clear that everybody understands it and everybody follows it.
Making changes to support documents.
Yes.
We always want to keep support documents current. So if a change is necessary, change it right away. Update that date of the document as soon as you change it so that it's clear what version we're using. And as we mentioned earlier in this session, you're going to update that date on the support document as well as on that ISP risks page. Yes. So it's really clear to everyone what version you're using.
Right.
And of course, use a change form to document that change was made and what approval was obtained. And of course, remember to train your staff on those changes and keep record of that training.
That's correct.
Quick conversation about, we know that there are templates available for the and there's a standard format for the Fatal 4, also for the financial plan. There is also now a PICA protocol that's available. I noticed that a question popped up in our chat window about is that new PICA protocol required to be used for everyone who is at risk of
No,
investing
it's
in
not.
the
It's a choice. So if the provider organization or the ISP team look at it and say it really needs, that's fine. If you have something else that's working or other forms or other support documents, it is not a required form.
But you might look at it and see if there's something on it that the version you're using doesn't include that would be helpful. So it's there and it's available. We also want to point out new in the last year, helpful resource. The Health Informer newsletter is published by Office of Developmental Disability Services, and we included a link here. After the webinar, you'll receive a link to download a copy of our slideshow, so you can have it there as well. We'll also include this link in the follow-up email that goes out so that you can go to the DHS website and sign up to receive the Health Informer newsletter.
Yes, and it's really, we're really looking at input from you as people who know what kind of health issues we have, some that we've identified. But the more questions we have, the more issues you let us know. We really work at trying to make sure that is a helpful tool for you.
There's a health advisory committee behind that newsletter, and that committee is working on issues right now that include risks related to falls, diabetes. They're looking at providing some guidance for support documents for diabetes, which I know many people have asked for. Here's also some other helpful links. Helen Sanderson and Associates, they're based in the UK. Gosh, they've got a lot of great reading and materials around person-centered approaches to risks and gathering person-centered information and a whole lot more useful. Do check it out. And here is a link to that article that I mentioned earlier on a person-centered approach to thinking about risk. We have, what we'll do right now is we will go ahead and post a real quick couple of poll questions. We want to hear from you how clear and easy to understand were Terry and I, your presenters for the day. If you give us a quick feedback there, we appreciate that. We'll give it just a couple minutes for that feedback. And while you're doing that, I am going to try to sneak in a couple of quick questions. Terry, can you give any guidance about clear ways to determine whether an issue is serious enough to rise to the level of appearing on the risk tracking record?
Well, I think in the manual it does this person, is it life-threatening? Is it something that would cause the person to be hospitalized? Or is it something that puts their living side in jeopardy? I mean, you're looking at the behavioral issues that can be really challenging that would impact their life, not only medically, but their living situation. So I think if there's a question, I would certainly go back and have the ISP team talk about it. You know, you could put it on your agenda, have a discussion about, we're seeing this, do we as a team feel it needs to be identified as a risk?
And to the issue of home protocols and work protocols, it says, is it okay for work not to have a support or protocol if it's something that work doesn't offer any supports for? If so, how should that be documented?
Well, work, if it's a risk, work has to offer support, unless it's not an issue that happens at work. So there is no out for work unless that particular issue is not a work issue.
Can you give any examples of things you've seen?
Well,
it doesn't happen very often, does it?
Doesn't happen very often. It may be that the person doesn't get along with their behavior happens at home because it's the interactions with their homemate.
Housemate.
But it could also be reversed. It could be interactions with their work coworkers, and then they get along fine at home. So there may be a place where you're having a support document for one site versus the other. But yeah, you can't just opt out not to have a support document if the person has a risk.
Well, we were talking about supporting people with challenging behaviors. Somebody asked a question, what's the difference between a behavior support plan and staff interaction guidelines?
Staff interaction guidelines are to direct staff on how to interact with a person to prevent a behavior. It should not include any components of the OIS. It should all be really focused on the positive and how staff need to respond when the person is showing whatever the concern is. A behavior plan is going to have those proactive pieces and the reactive pieces, and then that crisis intervention, crisis response. So you're really looking, you need to go in and look at behavior plans and look at the OIR around what a behavior plan needs to include. So if you have a guideline that's including some of those things, you don't have a guideline.
Then I'm going to crank out another quick couple of questions here because we're on a roll. If a program, if somebody here was listening as we were talking about implementing interim supports right away if something new is addressed, or consider a situation where you admit somebody new into your program, and so if a program is required to immediately address a behavioral risk for a new intake, can those behavioral protocols or supports contain reactive components until a formal FA or clinical support document is completed?
Well, those reactive will be emergency.
Yeah.
Yeah. So, and the rule allows for emergency. So you would have the positive and what you're trying to do to help the person, and any reactive you wouldn't write in. What you would have is everyone would be treated as an emergency event and need an incident report and all the requirements that go with that.
Yeah. And I had another one here quickly flagged. What about a protocol under the prevention section if the home handles constipation meds and work does not? Can that be listed on a work constipation protocol so that preventions are met?
Well, you're not going to be, if you're actually, the prevention is making sure, do you include making sure there's water?
Right.
Do they get exercise, get up, move around? Making sure they have abilities to use the bathroom at any type of schedule that's needed. So you're going to do some prevention there.
That's
you're not going to be giving medication, but you're going to be feeding that information back.
Yep.
So that's what you're communicating with the home.
Communication is the key.
It's
often
the key.
With those for the work staff.
Yes.
How clearly are you communicating what you see? And also for the home staff, if, gosh, that, 2 days have passed and we're watching for that third day with no BM, we're going to be especially clear to communicate with work that we haven't seen any bowel movement, and can you especially watch?
Yes.
And let us know.
And it's really critical because you don't want a person to get a medication that's not warranted. It's not very respectful. So that clear information going back and forth is critical.
Is a functional assessment considered a support document?
No.
It's not. If a behavior support plan results from that functional assessment, that behavior support plan or whatever other document is created that the staff follow, which would be whether it's staff interaction guidelines or any other tool.
Remember, the functional assessment is just identifying the situation and determining what needs to go in place to support that person, or whether it just needs to be, do staff need to do these things, or we need a formal behavior support plan.
Are there any risks that require a functional assessment if the yes box is selected that may not be covered under OARs? Trying to understand the question.
I think the assessment, the psychosocial assessment is in there, and I know that one's been a problem getting professionals who are qualified to make those assessments around people who have the sexual deviancy risks, and so that That one requires it, and I know what you need to do is make sure you're documenting clearly what you're trying to accomplish and how you're doing it so the team is involved, because sometimes I know those aren't happening, and it's a real problem.
So we have exceeded our time for today, and so we're going to have to wrap up for today. And Dan is going to walk us out with a few final comments. But thank you, everybody, for being here. Terry, thank you for taking time to be here.
Yeah, I really appreciate the opportunity to give you some information, and that you've taken the time to really participate. I know there's some great questions, and taking the time out of your busy day. So thank you.
Thank you.
So everyone, if you asked a question that we weren't able to address today, please contact us by phone or email and we can discuss your question. Just a quick reminder as well that this webinar has been recorded and we will post it online by tomorrow at www.otac.org/ISP/forum for you to watch or share with others. On behalf of the ISP and Person-Centered Practices team at OTAC, thank you and have a great day. Goodbye, everybody.